Welcome to my poster presentation on my ethnographic essay, BPD Weapon of Mass Invalidation. I'm Suze Hemming. Now, if you're after some meaty primary academic research to get your teeth stuck into, I'm going to tell you now that this is not your stop. This is an invitation into reflection. Now, to keep everyone safe who is viewing this poster, I do want to let you know that I will be discussing parts of my lived experience with this diagnosis. So that might bring up some difficult thoughts and feelings for those who have shared similar difficulties or journeys. So please do whatever it is that you need to take care of yourself. And with that said, I'd really love it if you could join me for the next 10 minutes or so, and maybe, just maybe, I can give you a little something to think about. So the aims and objectives of my essay, which I discuss in this presentation, is to explore from a dualistic lens of a service user turned clinician the clinical utility of pathologizing understandable responses to life experience, the impact of the stigma attached to this BPD label. What does it cost not just service users but clinicians alike? And to question the practice that has become so common of using out-of-area placements. And do they actually help us to support people move towards them discovering this life worth living? So now would be a good time for me to introduce myself. So I'm Suze, and I've lived experience of psychological distress from a young age, carrying, amongst other diagnostic labels, borderline personality disorder, or BPD. I've experience of using a number of different services, including day patient, community, acute inpatient, and on into Tier 4 specialist placement. I've worked as a peer support worker, both formally and informally, in the area of eating disorders, myself suffering with anorexia for approximately a decade now, thankfully living in recovery. And I qualified as an occupational therapist in 2023, now working for Sussex Partnership Foundation Trust in the acute day service, which is a group programme for adults in severe psychological distress. And because of the path that I've walked, I've a real passion for amplifying and witnessing this lived experience voice, and advocating for a reclamation of personal power. I want individuals to feel supported to reauthor their stories, which are so often sanitized or invalidated by this diagnostic lens, and put them back in the driving seat of their lives. So this passion has led me to explore the ways in which the BPD diagnosis can harm both individuals and clinicians alike through authoring an ethnographic essay. So on my poster, you will see another QR code like the one on the screen, and that will take you to a copy of my essay for you to read at a later date. There is also a link to this in the video description below. In this presentation, I am hopefully going to whet your appetite just a little by summarising some of the themes I explore within it. So let's get started. So since my diagnosis, my relationship to my label has undergone many iterations, which I've distilled into 5 separate chapters, and each are explored with observations from practice, lived experience, and contextualised with some literature. I cover assault and injury, the initial diagnosis delivered, internalization and self-stigma, the wound deepened, identification and finding a tribe, that double-edged sword, societal amputation on outsourcing to private specialist units, and de-identification and reformulation, that reclamation of self. So let's begin. Assault and injury, the diagnosis delivered. My diagnosis was delivered to me by mistake by another clinician whilst I was a patient in acute day hospital, having been decided on a few days previously by a psychologist in an hour-long session when I'd never met them before. I remember the initial assault And I say assault because it felt like an injury. It sounded more like a judgment than a diagnosis. It communicated something to me about the fundamental core of who I am being unacceptable and flawed. It was my deepest fear. And yet the predominant therapeutic aim of my treatment was to improve my self-concept. And yet here the attachment of the label was sending me on a path heading in the complete opposite direction. The impact that stigma had on me changed professionals' attitudes towards me, seemingly overnight. Previously empathetic members of staff were now meeting my distress with indifference or frustration. And primary care services that had been open to me just the day before became closed, and secondary care provision, well, it was limited. It also resulted in the denial of treatment. During a period of regular A&E attendances for self-harm, an agreement was drawn up between the Mental Health Trust and the local hospital, refusing to treat my injuries unless they were life-threatening. This meant that even wounds that were clinically recommended for sutures were dressed and left open. This was supposedly meant to discourage me from care-seeking behaviour. All it did in actuality was, understandably, to escalate my distress. It confirmed that the world knew it too, that I wasn't worthy of treatment. And not long after that, my mental health deteriorated further and I was admitted to a ward. In my clinical practice, I see confirmation bias in action. The notion of what you look for, you see. It shows up everywhere. I witness it in notes and in clinical discussions, how all actions of an individual with the diagnosis of BPD get seen through this lens. These simpler explanations of they just want attention or they're acting out. They're always chosen over a real exploration of any true deeper meaning behind the behaviour. And it's just behavioural is bandied about in reference to individuals, almost as if behaviour isn't a purpose-driven way of getting one's needs met. Now, I stress needs because it's often treated as if these people are just trying to get their wants met. Human connection is not a luxury, it's an imperative. Instead, these behaviours are spoken about as if they're less valid, as if the person enacting them is in some way less worthy of having their needs met. And then when attachment styles are enacted within therapeutic relationships, on wards or in the community, it's often talked about as if it were a conscious choice and not a primitive program whose genesis is deep within relational trauma that goes so often under-acknowledged. Internalization and self-stigma. The impact stigma had upon me was to, in effect, reenact my initial trauma of being othered. The emotional and practical rejection I received from services and professionals became further affirmation of my own self-rejection. All of my worst, most self-denigrating and deepest beliefs about who I was were validated. And yet the pain I was in wasn't. Therapeutic relationships were held up as a mirror, reflecting denial of my emotional world. As professionals withdrew at a distance, I too sought to distance myself from my mind and my body through increasing levels of self-harm. Now, let me be clear, none of these dynamics were, of course, the precipitating factor for my development of self-damaging behaviours, but they did perpetuate and fuel them. And the hopelessness that clinicians voiced around my future aspirations, Well, they only furthered my own. After all, when the disorder is in an individual's personality, how can you expect to recover from who you are? In my clinical practice, so often individuals carrying the BPD label have a history of interrupted attachment, and they look to those providing services to be that good enough attachment figure. And as social creatures who learn how to treat ourselves through how others treat us, it's understandable, isn't it, how stigma can undermine our goals around improving self-concept. I see individuals who introduce themselves with their label rather than their name. They have these internalized assertions of their needs as being invalid, and they walk in the room expecting rejection. Self-stigma can reduce the quality of life. It can increase these anxious, anticipatory beliefs and fears around potential rejection, both in social situations and in professional contexts. It decreases social connectedness and it lowers self-esteem and heightens our sense of hopelessness. Aren't all of these things therapeutic aims that we're actually hoping to improve rather than make worse? Identification and finding a tribe. The sole perceived benefit to my BPD diagnosis was that I finally felt that I had somewhere that I belonged. It was no longer Sue's against the world or Sue's against the professionals, but it was them against us. And I was part of an outgroup, sure, but an outgroup was still a group. It was the only place I felt that I had ever belonged in the world. What I didn't know at the time was the dangers of identifying solely with people who had behaviours every bit as self-damaging as my own. It minimised and normalised my behaviour. There was always someone who had done something that was more extreme or self-damaging. And so whatever it was that I'd done, I didn't think was quite so significant. Recovery became the threat. It was the threat of losing all sense of my belonging. If I were well, if I no longer acted in ways that were self-damaging, then I wouldn't inhabit the services and spaces where people who actually made me feel normal were. I would be alone again. I never fitted in the outside world, but in the world of sickness and disorder, in the world of vilified patients fighting an unjust system, I finally belonged. What happens when people who struggle with their self-concept and identity find it in a diagnosis with criteria that include such self-damaging behaviour? How do we expect them not to cling to a label offered, and then by clinging maintain that unhelpful behaviour that causes patterns of such distress? We all know that belonging is a core essential human need, right back from Maslow's days. And yet, when we are met with patients who are experiencing what we would possibly find in notes termed as admission seeking or resistance to discharge, somehow it is met with this sense of anger or annoyance or irritation. And yet, when you have such little sense of belonging in the world and you finally find it in this world of disorder, why would you want to give that up? Societal amputation and outsourcing to out-of-area placements. A couple of very long acute inpatient admissions had, unsurprisingly, failed to diminish my risk to myself. And if you think about it, it makes perfect sense that they didn't. Even if we were to use the medical model frame of reference and think about these difficulties as a disorder, no medication has been proven to have any significant impact on any of these core symptoms. I was eventually admitted to an out-of-area placement 170 miles away from home the week before Christmas in 2017. I was alienated from my support network. Up until that point, me and my mum had been so close that professionals deemed our relationship enmeshed. I would see my mum twice a day on the acute ward. Then suddenly, miles away from home, 4.5 hours drive, I saw my parents about once every month. I was completely divorced away from my friends, from my local community and my network and everything that I knew. It was really ineffective at re-establishing any meaningful occupational engagement. When I eventually got Section 17 leave for 4 hours a day, I had nowhere to go. I couldn't visit friends or see my family. I couldn't go to places I knew that I could access upon discharge. Instead, I spent hours nursing a single cup of coffee or walking in circles around a town that still felt foreign to me. Perhaps, though, the most damaging aspect of this placement was the excessive use of both physical and chemical restraint. And it reinforced the message to me that my emotions were dangerous, that they had to be avoided at all costs. And not only that, but it was incredibly distressing. The staff had no additional specialist training in order to call themselves a specialist unit. This was perhaps no more poignantly illustrated in the way in which they enacted restraint. I was subjected to restraints on a daily basis for hours at a time for non-life-threatening minor self-harm. And during these restraints, staff would, in quite harsh, loud voices, taunt me. They would assert my selfishness for taking away resources from the ward and how I think of no one else but myself. Bearing in mind, this is all while I'm in an acute period of distress. At no point would anyone try and verbally de-escalate me in a meaningful way. And the therapeutic support offered was inconsistent, and groups often didn't go ahead. Now, don't get me wrong, that unit saved my life, and I will forever be grateful to them for that, because it means that I'm sat here talking to you today. But there were other ways that that could have been achieved, and ways that didn't result in such a significant degree of iatrogenic harm. Eventually, I was discharged from the placement when the degree of chemical restraint became sufficient enough that I was completely divorced from all of my thoughts, from my feelings, from my body. But it strengthened my core beliefs about the selfishness of my distress and my worthlessness of who I am as a person, about the need to contain me and control me and keep others safe from me. The lack of bodily autonomy that I experienced from those hours of restraint, in effect, re-traumatized me from a really distressing memory of a past relationship. And I learned functional suppression. It exacerbated my obsessive compulsive disorder symptoms that I'd experienced from a young age and resulted in hours of me hand washing, trying to achieve a sense of safety that I just couldn't quite get to. I became functionally depersonalized at all times. I had no real connection to myself, what was going on inside or outside of me. And so I was able to walk through the world in a way that seemed more normal to others, and yet I was plagued by such intense, overwhelming distress. And my self-harm became rarer, and my service use was less frequent, and yet the self-harm became more severe and always resulting in surgery. And the long-term ramifications from the chemical restraint is something that I am still living with now, with an ongoing functional gut motility disorder, which I have to take drugs daily for as a result of the medications that I was given. Now, I accept that I am a sample of one. And I cannot speak for everyone's experience of out of area placements, and yet I have spoken to so many people who have similar stories. Does this really sound like we are helping people move towards an engaged, meaningful existence? So, a few concluding thoughts. Framing of the self as disordered, over-distressed, undermines our therapeutic aims, impairs clinicians' judgment, and amputates empathy, impairing healing. Relational, community-based support is desperately needed, focusing on people over service pathways. Clinicians need to be aware of, acknowledge, and to validate theirs and wider services' role in causing iatrogenic harm and challenging stigma. Guarding against ineffective, expensive, and damaging out-of-area specialist placements needs to be a priority, as does flexible, person-centered support over continued use of condition-centric reasoning. Nobody deserves to be told that who they are is disordered, and there are viable alternatives around working with functional presenting problems such as interpersonal difficulties or self-damaging behaviours, all without the need to use negative labels. So, I want to leave you with some questions for reflection. Through labelling someone with BPD, are we reenacting the powerlessness inherent in being traumatised by situating the disorder as part of who they are over the imprint of what they've endured? How do you see the system in which you operate perpetuate iatrogenic harm against those people who do have this diagnosis? How can you, as a clinician, honour an individual's narrative and capacity to heal rather than focusing on their symptomology? And how can you be an advocate to influence destigmatisation of those with understandable human responses to severe distress within the wider health and social care setting? Thank you so much for taking the time to visit my poster today and to watch my presentation. And I hope you have time to download my essay and to give it a read. Please do follow me on my Blue Sky channel and give my blog a visit that I update regularly. And please find my references below. Thank you so much.